Global development assistance for health dropped 21% between 2024 and 2025. The core driver is a single massive reduction. The United States government cut its funding by more than $9 billion. This contraction erases the financial expansion triggered by the COVID-19 pandemic. Total global health funding has now regressed to volumes last seen in 2009. Pulling $10 billion out of the global health system puts decades of targeted disease control at immediate risk. The sudden drop forces a complete realignment of how international public health is financed. This graph tracks global development assistance for health. After peaking in 2021, over $10 billion abruptly exited the system between 2024 and 2025. The FGH models show no recovery, forecasting a continuous slide downward to $36.2 billion by 2030. In this breakdown, the United States executed a 67% volume reduction in 1 year. The UK cut 39%, France 33%, and Germany 12%. Meanwhile, Japan and Australia increased allocations by 2%, protecting strategic steers in the Pacific and Southeast Asia. As state actors pull back, private capital has advanced. Preliminary estimates show the Gates Foundation has surpassed the U.S. government as the single largest funder of development assistance for health. Western bilateral aid can no longer function as the guaranteed baseline for global health budgets. Power and capital are now concentrated in private entities and regional alliances. Sub-Saharan Africa bears the heaviest financial toll, losing $4.6 billion. This effectively erases a quarter of its external health funding in 12 months. This map shows the projected relative reduction in total health spending. The deep red and orange areas face the steepest deficits. Malawi is losing 17% of its national health budget, while Mozambique, Lesotho, and the Gambia face drops over 14%. This chart illustrates the immediate institutional impact. Non-governmental organizations and UN agencies are absorbing the largest volume of these multi-billion-dollar cuts, directly restricting their operational capacity on the ground. High-income countries spend 299 times more on health per capita than low-income countries. To quantify that disparity, the average low-income nation spends just $40.29 per person annually, inclusive of government, foreign, and out-of-pocket allocations. Countries with the fewest resources have no mathematical path to tax or spend their way out of a multi-billion-dollar shortfall. The void left by retreating international donors cannot be filled from within. This chart maps the rate of global deaths from HIV/AIDS over 3 decades. After the U.S. established PEPFAR in 2003, targeted interventions drove global mortality down by nearly 2/3. That exact trajectory is now at risk of slowing or reversing. Without an influx of new domestic revenue, these health systems must execute strict efficiency overhauls immediately. The alternative is direct rationing, cutting citizens off from essential medicines and life-saving care. The period of abundant external health funding is definitively over. For many nations, maintaining the health of their populations now depends entirely on forced, rapid optimization.